Well, hello there, my friends. The microphone is too low. Okay, here we go. Oh, my chat's not showing. Dude, I made the thumbnail and I'm like, yo, my chat's not here. Hello, Maddie. Hello, viewers. How is everyone doing today? Just be aware, I have a little bit of a cough and that's pretty much it. So yeah, the mic is fine. Hey, Moshi, how you doing? Welcome to the stream. So yeah, hopefully everyone's been doing well, you know. I've been suffering in the ER. How's the ER? I'm done. I'm done for the week. I don't have ER for like another week until I start my EM rotations. That's a fun time. But yeah, ER was good. ER was fun. I mean, definitely a different climate for sure. I could definitely say that the ER is, gosh, very interesting place. Like, the physicians and the culture there are very different than what you'd see in an outpatient clinic or just like on normal ICU or inpatient floors. Because, you know, it's very fast paced. You don't know who the fuck is coming in. You gotta figure out a history in like 2 seconds. Should be stressful. I mean, depending on the day, like I was in specifically pediatrics. So it's like kids usually come in with like colds. And sometimes they come in, it's a lot of babies too. They're like really cute, man. It's like sometimes I saw like, oh man. I saw like from 5 weeks old to about like 17 years old. Am I in training? Yes, I am. I am a student. I'm not a physician. I'm currently in my 3rd year of medical school, so everything goes well, right? I'll be graduating hopefully in a year, so that's exciting, right? Hopefully in a year, and I'll go to residency training. No long-standing patient relationships. Yeah, of course. There are no patient relationships in the ER simply because, you know, that's how it works. People come in and out, they have acute complaints, then they get sent home. Welcome to the emergency room, my friend. It's a fun time, but it is exhausting. Like, I had my shift today. And it was just like, get me the fuck out of here. I want to go home. I want to do shit tonight. What happens if a patient gets sicker by a bad treatment of a student? Well, here's the thing. So students aren't the ones who give the treatments. Like, usually how it works with every rotation is every good rotation. There are some bad ones that do the shit, but the shit that you said. But in terms of the ones that I've went to, right? The student usually practices their patient interview. They do all that stuff, and then they present to a resident or an attending, someone who's higher up than them. So, for example, I had a resident that I followed around. I presented to her. Then she presented to the attending along with my input, and that's how it works. So it goes through multiple layers before, you get your proper treatments. The patient is being seen by the actual physician. It's just that the residents and the med students, see him beforehand, and they help figure things out from there. So that provides the patient with the care they need, but also provides the student with the education they need. So it's really nice to see how patient interviews work. But yeah. Nah, don't forget homeless Bob. Oh yeah. EDs are a very common place for the homeless population because, it's a warm bed, free food, everything. So you see a lot of homeless people come into the ED with various complaints, and kind of hard to kick them out. I mean, you could probably discharge them with a clean bill of health after seeing them, and then they'll come back. So it's like you can't really stop them, can you? So it's another problem with the ED. But yeah. That's basically how the cookie crumbles in that regard. But yeah, I'm done with the ED for a week. I'll probably tell you guys more when I go on my EM rotation in a week after I take my exams. And yeah, again, of course, if you guys have any questions about stuff that you want to know, I'd be happy to answer. Again, all of my streams aren't medical advice. As always, see a physician, see your doctor if something goes wrong with you. I'm not diagnosing your conditions because I can't do so. I'm a student, for Christ's sake. Ask someone else, not me. But yeah, babies are so fragile. They are. They are so tiny. They are so tiny. Like I saw a 11-day-old baby today. They are the tiniest fucking thing, and they are so fucking cute. I did the exam. I was like, God damn, this baby is crying so much, but I am so sorry. I feel like the most traumatic experience I had. You guys remember the catheter thing we talked about last week? Yeah, if you guys don't know, if a baby is getting an infection, the most likely thing is like a UTI, urinary tract infection. And the cleanest way to get a clean urine sample from a baby, because, they can't move, and it's going to be a pain in the ass to catch it, is a catheter. A very, very, very tiny catheter. The amount of trauma the first one that was done caused me is unmeasurable. That shit was crazy. Like, you gotta like, if the baby is uncircumcised, and yes, you do a lot of genital exams in peds, the baby is uncircumcised, you gotta retract the foreskin, then you got to lube the catheter, shove it in there, all while the baby is crying and trying to fight you, by the way, because baby don't know what's going on. So all that time, I'm there holding the fucking baby's legs down for dear life because, damn, bro, those fuckers fight. Babies are fighting, dude. They are kicking, screaming. Oh my god, it was an experience and a half. The one I did today, though, was pretty nice. Baby was chill, but dude, it is... And then the worst part is that when they fucking pee all over you when you're putting the damn catheter in, so you gotta wait for them to pee again. It's like, oh my god, dude. Anyways, enough venting about me. If you guys are ever interested in hearing the pain and suffering of my existence, then let me know. But yeah, I am doing EM soon. Another thing is that I've been auto-posting a bunch of shorts recently, on YouTube. Some of you guys might have found me from there. And I really appreciate the amount of traction that I've been getting and you guys have been giving me. So I always appreciate that. The past stream is really entertaining, and we can definitely see it in the clips that were covered. Again, if you're from Shorts, and if you're on YouTube right now, you're watching there for some reason, then pop by on Twitch, say hello, because that is where we're chatting today. But I've been yapping for long enough, and I think an ad break will be starting soon. Let me just make sure. Yep, that's right. So let's run the ad real quick. Actually, I think I'll yap for like a couple of seconds more because it starts in 48 seconds. So yeah, the main thing that I like to talk about in terms of, rotations is that it's pretty hard in this situation. Like, I've been in and out. I've been like in 9 to 3, 3 to 9 shifts. That's just been exhausting. So if I have like low tone or I'm just chilled out or more laid back this stream, I apologize. I'm just a little bit tired. Stream was originally meant to be tomorrow, but like stuff came up, specifically IRL hangout, and yeah, so that takes priority. But yeah, apologize for the stream delay. Nevertheless, I'm gonna run the ad right now, and then we'll regroup back and talk about today's topic. See you guys in a second, and we'll just talk if you're not getting ad stuck. Okay, let's let this shit start. And yeah, so if there's any questions y'all want to ask about the stuff that I'm doing, feel free to let me know. I'd be happy to answer. I am more laid back and more tired, so I probably answer more than I need to, but I'm more than willing to answer. Oh my gosh. But yeah. For all you guys that, hopped in the VC, I thank you guys for, chilling, chatting while I was fucking editing and shit. That shit was fun. Always interesting to talk to you guys about stuff that you've done. And and if you guys ever want to do a collab together and yap about stuff on stream, hit me up. I'm down. It just depends on what I'm doing that week. That's all. Yeah, have you ever put a cat in a female patient? I didn't put the cat in. I watched the cat being put in while holding the baby down by their legs. But yes, I have seen the female patient, and it is even worse because the pee hole in women is tiny as shit, especially in female babies, because it is really fucking tiny. Women don't have a penis, so it is difficult to do that. Sorry, females don't have a penis. Don't want to offend anyone out there. Sorry. Oh man, hell not. Well, hey Xerox, but yeah. You don't want to know what the fuck. Oh yeah, I saw a lot of trauma cases as well. I saw a case of an anaphylactic reaction in a little kid. I also saw this kid. I also saw this kid in the ED. She was there, and she was like, had like this rash on her face and shit. She was like, wait a minute, hello. She was saying that to everybody. It was the cutest fucking thing, dude. Oh my god. Yeah. Oh my god. I can't even. This was in like the late shift too, so it was really nice. And one of the attendings, right, when I was there, he was such a G, bro. He was a G. He was awesome. But the attending was basically just like, whenever you went to the kid had like a stomach ache. And he's like, hey, did you bring a muffin for me? You know you're supposed to bring a muffin or a cookie for your doctor. Where's my muffin? Where's my cookie? The kid was so confused. Like, what the fuck is going on? Oh man, I love docs like that. But yeah, enough about me talking about my rotation. So today's stream, you guys had a lot of enthusiasm for this stream today, so I'm very happy to present to you Drugs, the stream. We're gonna specifically be talking about drugs themselves and the educational aspect of them. We're not gonna be talking about how to do them, obviously, because you shouldn't be, right? Again, oh yeah, that's the title of the stream. We're cooking today. You see, we got Monami here. We're gonna cook up some shit, bro. Hell yeah. But yeah, we're gonna be talking about the medical education of drugs and how they work, because previously I was in my psychiatry rotation, and in psychiatry, you learn a lot about drugs, intoxication, withdrawal, and all those stuff. So I feel like it would be a good idea to, educate everybody on how these things work. I know there's some nurses and physicians in the chat here, so if you guys do want to chime in, if I'm saying something wrong, please let me know. Like, I'm just a student. I have a lot of things to talk about, but yeah. I'm grabbing the meth recipe, right? Yeah. So, if you guys are in my Discord, you guys have suggested a few drugs that are more on the more esoteric side of things, but I am more than willing to talk about them, and I did my research just to make sure. So we'll talk about those in the latter half of the stream. But first, we're going to talk about more of the conventional drugs, and then we're going to get further into it. All right, so let me first set up my 5K, my screen capture for my iPad. But while I'm doing that, tell me what you guys, do you have any experience with this type of stuff? And this is a completely open chat, no judgment here. So if you guys do want to share like your personal experiences or things that you've gone through, then I'm happy. I'd love to hear it, and it would be very interesting for the stream. But if you don't, that's okay too. Everybody has their own demons, just like me. I have the Demon of Monami that is on stream here. Also, if you guys do want the angel outfit, like this outfit, just let me know. I'll be happy to switch it at any point during the stream if that suits you or something. But we could just stick with Monami's casuals for now. That's pretty. Those are pretty nice. All right, then. Without further ado, let me open up some shit. Besides the morphine incident, nope. Okay, gotcha. Yeah, I'd imagine most of you are clean. I think there were a couple of people that joined the stream a different day and were talking about their withdrawals and stuff, which was very interesting. So yeah, TLDR, my post-op pain management has never really worked. I just throw it up and suffer even with Zofran. Damn, this sucks. Well, drugs don't work on everyone, my friend. Okay, this is my browser. We're gonna hide that for now. We don't really need to use the browser today. Let me just hide that. Where are you? Nope, that's not it. Where is it? Oh, there we go. Yeah, there wasn't a guy who was drinking since they were 12. Yeah, oh yeah, wasn't there a guy who was? Yes, there was. I remember him. I'm not gonna say his name, but I remember him for sure. That was a very interesting stream. Wonder if they'll pop back in again. That'll be fun. But yeah. So, first of all, what do you guys know? Let's just ask the chat. What do you guys know about the science of drogas? The drugs. La drogas. The Diablo of the pill world. You see, there are two types of drugs, right? There's the legal kind, the ones that you get from the doctor, and in a prescribed manner. And they are, you know, supposed to help you. They always have side effects, obviously. But then there's the illegal ones, which is what we're illegal / recreational. Recreational can involve, you know, legal drugs being abused. So the number one thing about these is abuse, right? And then illegal drugs are also harmful in large quantities. Like anything technically is harmful in a large quantity, but these drugs are more so, right? They don't really help you. They're more so for pleasure. And they're made to, you know, give you a high. So you guys agree with this, right? There's, like, legal drugs are prescribed to you by a physician because you have a condition. Illegal drugs are obtained for illegal ways or by abusing the prescription drug system in the case of opioids. So yeah, that's the main thing. But the thing we need to cover is something called neurotransmitters. So let's just explain some basics about the nervous system. And if you guys don't know, the nervous system is the main part of the body that deals with, like, you know, emotions, mood, personality. It can also deal with seeing, senses, movement, pretty much anything that involves conscious or unconscious feeling in the body or action is the nervous system, right? So for example, you got your happy, sad, you got your heartbeat, breathing. You also got movement, memory. These are done in the brain, right? And the rest of the body and the spinal cord, the nerves, whatever. So, we're gonna focus on this part today because this is the main part that is what makes illegal drugs very pleasurable. Right? So, let's go over the pathway here. It's a pretty simple pathway. But there's one thing we need to understand first, is the basic unit of a nerve. So a nerve is just the basic cell. You have cell body, the thing's called the dendrites, you have the axon. That really doesn't matter for the purpose of this stream. What matters is the synapse here. So the synapse is in between two neurons, right? And this is how neurons communicate with one another. I'm not gonna go over the entire basic biology, neural connection shit. That's not the purpose of the stream. But basically, we're gonna be focusing on the synapse here. So let's draw the synapse. This is our axon. So we're gonna call this pre, right? So pre-synaptic. And this is our end axon. And this is our postsynaptic terminal, which is our like cell body. Okay? And to communicate between these two neurons, we use something called neurotransmitters. Small chemicals that are released from neurons to send a message to another neuron. And every neuron has its own properties with these neurotransmitters. That's how the body is able to do so many things with just a set amount of neurotransmitters. So we got ones like glutamate, GABA, serotonin, dopamine, what else? Glutamate, GABA, serotonin, dopamine. Yeah, we could say those are a few. But yeah, those are just a few of them. I don't exactly remember all of them because I'm not a neuroscientist. But yeah, which one of these you guys know about? Oh yeah, there's also acetylcholine. That's also one we're gonna cover. But yeah, there's a lot of them that you guys know about. But from you guys in like high school biology or something, or just like health class, can you guys figure out which neurotransmitter acts on the drug reward pathway? Like what makes you feel happy, feel pleasure, give you rewards whenever something great happens? What do you think will activate in this case? Because it's very, very important. Dopa. There you go. Dopamine. We covered this in August. Well, you're covering it now. So dopamine is the main neurotransmitter that is used for reward. And the pathway for getting happy, well, not exactly happy, more so getting pleasure, getting reward, getting, I'm not going to say the word, but getting in that state is very simple. So this occurs in a part of the brain, right? It's usually like about here, called the limbic system. Now the limbic system is known as the emotional part of the brain. It's just a bunch of regions of the brain connected together. But in this case, we're going to focus on a specific area called the VTA, or the ventrotegmental area. Don't worry about the name. It's just the area where dopamine acts on for rewards. Okay. So in the VTA, we have our neurons, right? So we're just going to say this is the presynapse, and this is the postsynapse. Neurons, when activated, will release dopamine and then act on the postsynaptic neuron, which will act on the VTA of the limbic system to produce the reward, also known in drugs as the high. Right? So you get a high by stimulating this area in some way, shape, or form. Now, a high is not because of a drug. It's not chemically made. It's natural, right? Whenever you feel reward for, let's say, winning the jackpot at a gambling, at a slot machine, that releases dopamine. Working out, right? That's called a natural high. So working out or playing a game, beating a tough boss, right? These are examples of natural highs. So this will release rewards. Yeah, smashing things. That's another thing, right? This will help act on that dopamine system so that it gives you that same high. So just to put it out there, the high is not exactly a stimulated thing. It's a natural thing. It's just that, you know, these chemicals allow it to be much more than it usually would be. And that's the, you know, main thing in addiction, chasing that high. Hopefully you guys understand what I'm trying to say here, you know? But essentially you're chasing the high, trying to get to that point where it's just like, oh my God, this is so pleasurable. This is amazing. I want to do it again. And the do it again thing is the problem. So that's the biggest issue of addiction. Hey Zataris, welcome to the stream. Thank you so much for the follow. Welcome in, welcome in. We're talking about the pathophysiology of drugs, and I just explained a brief overview of the nervous system. So yeah, if anyone has any questions, let me know. Hey, how you doing? Welcome in, welcome in. All right, so now continuing on, we talked about natural highs and we talked about artificial highs. Well, I'll do it again for the gym. For example, in my case, right, I go to the gym a lot. I'm a big fucking workout addict. And I go like every weekend, get myself strong, you know? So I love to do it again. It's like you have to get your ass up to go to the gym. But once you're there, it feels so fucking good. It's amazing. And I always recommend, if you can go to the gym, go to the gym. Please, for the love of God. It's amazing. It'll keep you healthy and it'll keep you happy, right? Anyways, that's my gym ad there. Go to the gym, get yourself big, and make yourself fit and healthy. Nevertheless. Listen, I'm gonna promote the gym and exercise all the time because that's what I'm supposed to do. Good. When I'm interviewing a patient, you got good diet, you got good exercise, you eat processed foods. Gym can be an issue. Heard of someone who was going 5 to 8 hours listen, power to you if you go to 5 to 8 hours a day. I mean, if you do too much of anything, it'll hurt you, right? That's the main problem. Too much of a good thing is a bad thing. That's why everything in moderation is good. But this comes in the form of drugs, where too much of one thing could cause severe health issues. All right, so we just went over the basic reward pathway here. Now, it destroyed her marriage. Jesus Christ. So yeah, that's a form of an addiction for sure. God damn. Like, being addicted to the gym like that is crazy. I think I know someone who told me about this. Like, same thing. Like, they're way too addicted to like the fucking gym lifestyle, and it's just like, in my opinion, I know a lot of people who are into the gym, right? They balance out the gym with their work and stuff like that. Some of them go every day, some of them go like just a few times a week like me. And that's like what a casual person does. So you see these people on like Instagram, you see these people on Twitter posting like, you know, oh my God, I'm so swole, you have to go to the gym all the time now. Like, don't do that, please. Like, focus on you, focus on things that you do, focus on stuff that you know, focus on your work, your family, whatever, and make your priorities straight. That's all I'm saying, right? But anyways, so let's talk about the first class of drugs, the stims, or the stimulants. The biggest recovery time is a lie if you're on peds. No, I hate you. I hate you. Oh, man. I got sick in peds, man. That sucked. I could not stream to you guys because of that. I was sad. I was stuck all at home, just existing. I wanted to stream so badly. Anyways, so let's talk about stimulants, right? So stimulants, you know, are stimulatory. So they'll increase your blood pressure. They'll make you, they could make you have like a sort of manic like symptoms. If you know, like mania, it's like the talkativeness, you're like racing thoughts, right? You could also be sweating. You can have diaphoresis, everything's dripping down. You're like, oh my God, I'm so crazy, I'm happy. Oh my God, everything is going at like 100 miles an hour. Yeah, it's like you have ADHD, but you don't. I know my friend Zotaro is like, I feel like she's on stimulants. I think she is, but because of ADHD, but yeah, it's turbo ADHD. Exactly. So it's ADHD, but it's in the case you're intoxicated. The important thing with stimulants is that you could either have stimulant intoxication, or you could just have a psych disorder, a psych disease. So to rule that out, you literally just look for symptoms like these, like the more objective findings. Well, if something is just really smart or fast, it appears just like they're manic. Yeah, Zataris, that's where the psych diagnoses come into play. Smart and fast person might just be ADHD. It's possible. Or maybe that's just how they are, right? It could be like they have nothing wrong at all. Or it could just be that they have bipolar. Who fucking knows? Like, nobody knows at all. Yeah, exactly. It might just be ADHD. I mean, I know I'm fast. I know I also don't have ADHD, so it could just be the personality of the... It could just be the personality, right? Like, there's a lot of categories for diagnosing psych disorders. I'm not going to go into them because that's not stuff that I want to talk about today. You should probably hit up my friend Lev for that. She's a psychiatrist. She's a great VTuber, but yeah, it was interesting. Psych isn't drugs. Psych actually is... Well, psych diseases aren't drugs, but addiction psych, right, is a subset of the greater deal of psych. Like, if you learn about drugs, you're either looking at internal medicine, emergency medicine, or psych. So let's explain, before I get into like the specific drugs themselves and the stimulants, let's explain like the chain of command in the hospital in terms of where you'll see drugs, because there's different places and different specialties that you'll see different areas of addiction and drugs. So since 0x stated psych, let's start with psych. So psych is mainly the people who are on drugs and, you know, want to do something about it. So that's usually the rehab phase, right? So rehab is one. Also, heavy intoxication. Basically, if someone is super intoxicated with the diagnosis, a psych disease, that's reason for admission. But most of the time, you're going to see rehab, addiction, intoxication, basically like chronic drug use. You're gonna be looking at that in psychiatry. Can we measure serotonin, norepinephrine, dopamine, cortisol, or melatonin with the device? Okay, Moshi, that's a very good question. So there are a lot of ways to measure neurotransmitters, right? Because they're all over the body. Like urine is one example, but you don't some of these neurotransmitters can't really be measured. Also, cortisol is a hormone, not a neurotransmitter. It's a different thing. But there are various, and so is melatonin. There are various different tests to measure these neurotransmitter levels, such as blood tests, urine tests, whatever. Some of them, you know, like cortisol, they wax and wane throughout the day. So they could be inaccurate depending on when you're getting in the thing. But yes, I don't think you can measure it in real time, but you can measure it through a blood test for sure. It's not like glucose where you can just like measure as your blood's flowing. Maybe you can, but it's not really necessary for most things. Most of the time, neurotransmitter things can be measured clinically, so not really a big deal. If there is something, let me know. I know Hika is a radiologist, so he might have some fucking crazy ass radiography thing that that measures neurotransmitters. I don't fucking know. I mean, a PET scan can technically measure brain activity, fMRI as well, but those are like separate things. They aren't measuring neurotransmitters. But yeah, so back to psych, right? So in the hospital, you'll see psych for your chronic drug use. Then you go to a place like emergency medicine, right? So the ED, you'll see intoxication primarily, right? There are patients that'll come in. They have a ton of intoxication. They have a ton of drugs in their system. And next thing you know, they have some sort of intoxication. Either they have their pinpoint pupils, or they're going at like 150 miles an hour, or they need a psych consult because they're going 150 miles an hour, or they're not breathing, you know? So intoxication is certainly the thing you'll see in EM, and you won't really see much else, to be honest with you. Intoxication, also homeless, right? Unfortunately, a lot of the homeless population are drug users, so you're gonna have those hand in hand. Also, you might see relapse, right? That's another thing, but that's really what you'll see, the acute setting. I'm gonna put chronic here. Now let's go to primary care, right? So this is usually family medicine or parts of internal medicine. This is where you're gonna see the patients that are addicted, right? But they're in it. They're basically in the stage of being addicted. They're not in rehab. They're not actively trying to get help. They're just there. And it's basically a primary visit. So like for physicals, for example, right? So this is the outpatient side. And the things that these providers tend to ask are like, you know, we always ask about drugs, alcohol, and tobacco. Also caffeine, which it is a drug, but it's not as, you know, frowned upon as these three. And these are always sensitive, so patient might not always give you the information. Again, it's always confidential unless it breaks the rules of confidentiality, but majority of the time, your stuff's gonna be confidential, especially with stuff like this. Okay, so when it comes to drugs, alcohol, and tobacco, we usually do questionnaires, but we always ask, like, have you tried to quit? Or like, are you planning? And the reason why is because, you know, as physicians, we want to encourage people who are on these drugs to get off the drugs if the consumption is concerning, right? We don't want that to happen to any patient. But again, there's a lot of things in the way of getting off. Some people, and there are 6 stages, so let's go over them. So there are 6 stages of addiction, the addiction cycle, basically. So first we start with pre-contemplation, which is basically denial, right? You don't have a problem. There's nothing wrong with me. I just take this for myself. And the pre-contemplation stage, it's like, you can't really do anything. You just give them the meds that they need and they go home. And that's literally it. You tell them, like, here's the side effects, here's the bad stuff, and then you can't really do much. Then you go to contemplation, which is, acknowledging a problem. Let me just look it up real quick. Pre-contemplation, contemplation. Oh, yes. Sorry, I remember it. There's research. So you have you have a problem, and you're researching the ways to get help, figure out what to do. Then you have the plan of action, which is you're acting on it. So you're acting on the plan that you previously discussed with your physician, rehab specialist, whatever. And then once you've gone through the action stage, you go into maintenance, which means you're keeping yourself sober on the wagon in the case of alcoholism, right? But that's similar for other drugs. But then the one thing you want to avoid, right, because the cycle is relapse, where you basically go back to it. You go back on the drug, and then it happens again, and you can get re-addicted. You can always go back from relapse to maintenance if you're not on it for long enough, but usually if someone has been addicted once before, it is easier to get them addicted again because they're already used to that feeling, and they get that feeling again, they're like, oh my god, I love this thing again, let's do it. Zataris, I have denial. I don't believe I have ADHD. I acknowledge I have an attention problem. Oh my god. I never heard of on the wagon before. Yeah. On the wagon. I guess it's like a phrase that was more said in like earlier years of the 2000s, maybe 1990s, but on the wagon is basically like, alcohol. It's usually corresponding to alcoholism, right? If you're on the wagon, that means you're there. You're off the wagon, that means you're gone, Yeah, Maddie, it was back in your time, is what I'm saying. I'm sorry. Okay, anyways. So, hopefully that makes sense as to what you'll see from a primary care perspective. You're basically going to see all of these things in all of the perspectives of medicine. And yeah, like you really won't see this much stuff in surgery unless it's like drug complications, like cirrhosis, right? Or what's the other specialty I have to do? OB is another one where you could see kids that, have drugs in their system. We could talk about that later, actually. It's a very interesting one because I did have a patient that had some issues with a neonate that had some issues with drugs. And it's not what you think, obviously, but it's something else. Excuse me, sir. Yeah, you heard me. Hey, you joke about it all the time. Listen, man. I can't joke about it too? Come on. I'm kidding. Okay. So let's look at the first stimulant that I want to talk about today, which is cocaine. The cocaina. The stuff that was smuggled around by Mr. Pablo Escobar in the 90s before he got arrested and put out for good. He got killed. But yeah, let's go over cocaine. So cocaine is a very, very interesting drug. You want to know why? Because it's a stimulant. It makes you go crazy. And unlike other, do they allow medical students to treat patients? No, we don't directly treat patients. No. In some rotations, maybe. That's just like a shitty rotation, a shitty hospital. Never go there. But usually, like, medical students will not outright treat patients. The attending is your provider. The attending will treat you. That's pretty much it. Like, they will see you. It has to happen. Either they'll see you with me, or they'll see you after I see you. Right? That's how it works. So, yeah. I mean, a medical student can give suggestions as to what's happening, like we should, right? We give a differential, but no, we do not treat. Once they graduate, then they can treat. Yeah. Resident physicians can do that too. Even resident physicians, right? they may not also, help. Like in terms of my OMT stuff, like my OMM stuff when I was in that rotation, I did, do treatment, but only with the attending supervision. So that was fun. That was interesting. And you can do procedures in the rotation, like I did the catheter and shoved up a baby's penis, but that was, I mean, I didn't exactly shove it up. I helped, but that was basically under supervision. Yeah. So yeah, it's all under supervision, basically, is what I'm trying to say. But yeah, let's go back to cocaine. So if we go back to the presynaptic and the postsynaptic area of the VTA, so let's type presynapse and postsynapse. I'm just gonna write pre and post at this point. So in the synapse, right, we have our dopamine release normally. However, what happens is there's usually a set amount of neurotransmitter that exists. So let's just say there are 4 of these Ds at any time. This is basically when the neuron is secreting dopamine, there's always going to be 4 neurotransmitters existing because excess gets cleaned up or taken back in by the presynaptic neuron. There are a lot of proteins and pathways that allow for that to happen. We're not going to talk about that, but let's just say that there's a set and controlled amount of neurotransmitter outside on the synapse for a given period of time. Some idiot is revving his car outside. I apologize. Fucking muscle cars, I hate them. But yeah, so what we need to understand... Oh, okay, never mind. We got an ad break. We're not going to understand stuff just yet. I hate Twitch ads. Fuck you, man. I need to put this up, sorry. Oh, shit. Whoops. Sorry, I'm just drinking a good amount of water today. I have a bit of a cough. Oh my gosh. Ay. This is what I hate about ad breaks. Take 5 years. But yeah, if you guys got any questions about the stuff I say so far, and you guys are supporting me or you got an ad block on, just ask me. You see that Elon is gonna get 1 trillion in Tesla stock? I don't follow that shit anymore, man. I just don't care. Why the fuck do I give a fuck about Elon, bro? I don't really give a shit at all. I haven't seen it. No, that's interesting. That is definitely interesting. For sure. I just stopped caring about this type of stuff. Maybe it's because I'm employed now and it's just like I'm way too busy to care. But yeah. I went on VTuber Twitter and it was there for... Bruh. Why? Why the fuck? Who cares, bro? I never understand, like, the hyperfixation for these things. It's fucking stupid, in my opinion. Anyways. Sorry. Wow. I need to get some cough syrup in a second. Alright, ad break's over. Okay, so let's go back over cocaine again because the ad break happened and rudely interrupted me, by the way, you fucking stupid ass platform. Okay, so we got our cocaine, right? So we got the presynapse. And then we got the postsynapse. Right? So the presynaptic neuron and the postsynaptic neuron release dopamine. So this guy releases dopamine here. And at any time, only 4 of these dopamine will exist in the synapse at a time, assuming that dopamine is being released in a controlled manner. Any excess dopamine will be reuptaken into the presynaptic neuron by various mechanisms. So, let's say, what would happen if that reuptake is inhibited? Right? You don't have the reuptake of dopamine anymore. Well, this means that any dopamine that's released will stay in the synapse. Take a guess what causes that reuptake to be blocked. Cocaine. Cocaine will block the reuptake of dopamine, leaving more dopamine in the synapse, allowing it for an increased reward, which equals a high. So, since cocaine does this, it'll give you a high. In addition, it's a stimulant. So it's going to make you go insane. It's going to make you have those be hyper-vigilant, racing thoughts, all of that stuff I previously mentioned. Hypertension. Going to activate your sympathetic nervous system. One interesting sign from cocaine is, well, actually 2. One of them is in your nose. Your nose can actually thin out so much because the sympathetic activation is causing tightening of the vessels that you're going to see. Let's just call this like the nasal septum, the part in between your nostrils, is perforated, right? It thins out so much that the nasal septum perforates itself. And you can stick like a Q-tip in between them. That's how bad it becomes with chronic cocaine use. Because you're constricting your blood vessels so much that it thins it out. Yeah, it thins it out like a tiny piece of paper. Exactly. And this is, you know, the principle of other like nasal decongestants, right? That are much safer that you can use while you're sick. But this is, you know, ends up getting no blood flow. Exactly, right? It's gonna get no or reduced blood flow. Okay, and the second one is if you ever hear bugs crawling on skin, this is cocaine, right? This is cocaine intoxication because you're so hyper vigilant, hyper aroused, like, I'm so excited, oh my god, like, you're gonna start feeling like things are crawling around on you, like the creepy crawlies, you know? So that's cocaine intoxication in a nutshell, right? So you're gonna have the same stuff as stimulants, but you're gonna have these two feelings as well. Okay, so that's cocaine. Let's go to cocaine's bigger brother that you guys mentioned before. Jesse, we need to cook. We need to cook, Jesse. Methamphetamine. Jeez, if people knew this, I don't think they'd be doing cocaine. No, people know this. They still get into it. That's the thing. Like, I mean, medical education can only go so far, right? You see in health class all the time, like people say, don't do drugs. They're bad for you. Here's what can happen, etc., etc. People will still do it. I'll explain like the main factors that allow people to get into it in the first place. It's very sad, but there's a lot of things out there. But yeah, Dare is one. Yeah, there's a lot of things. I think there's also Truth. I mean, that kind of fell off, but there's a lot of things out there. But yeah, let's talk about cocaine's big brother known as meth. Oh my gosh, this is a very interesting one. So, meth, also known as amphetamines, are acting in a different way, very similar to the cocaine system. It's a stimulant, right? So it's gonna increase the amount of dopamine to give you that reward and give you those stimulating feelings. So let's write the presynaptic and postsynaptic again. And let's write post. So with amphetamine, we need to understand one thing. In the presynaptic neuron, neurotransmitters are packaged in vesicles. Right, so these vesicles are little pores that bind to the membrane of the axon, which is where everything is sent, and that gets released into the synaptic cleft, right? The synapse itself. So normally, these vesicles are packaged with a controlled amount of dopamine. Now, we have a small problem. Let's say we take an amphetamine. We're gonna call it AMP for short, right? What it does is it essentially acts on this vesicle, or specifically it acts on, acts on the vesicle, and then what happens, we're gonna make this arrow here, is that the dopamine gets displaced for the amphetamine drug. But where does that dopamine go? Well, it goes out here. And what happens to all that dopamine? It gets released into the synapse. So you're gonna get excess dopamine plus the existing dopamine that was previously released, which will act and give you the same reward, which will give you the high. Now, one thing you need to notice is that this pathway, double dopa combo, exactly, it's way more complicated than this pathway, right? This is just inhibiting reuptake, but this one is going to the source and replacing it. Unfortunately, this also means that it takes way longer to wear off of amphetamines compared to cocaine. Cocaine intoxication, it's quicker to wear off in the hospital. So whenever you have a patient, right, this is something that's usually on my testing material, if you have a patient that has like a short course of intoxication with a stimulant, it might very likely be cocaine. But if it's a long course, it takes a longer time, and you have similar symptoms, then that's when you gotta start thinking about meth. And yeah, so that's how this works. And the main thing you'll see with meth, right, because they're so agitated for a much longer period of time, you're gonna see skin excoriations, and I'll show you what those things are. And you're gonna have something called meth mouth. Do you guys know what that is? It's basically when you open your mouth, your teeth are gonna rot and fall out. due to the chronic use of meth, activating it. Okay, I'll show you guys some images. Just a warning, these will be graphic, so just keep this just discretion advised, okay? Okay, let me look up some images. Meth mouth and skin excoriations. Okay. I'm gonna search meth here. Here we go. I'm just a regular viewer with no medical student knowledge. Okay, yeah, that's fine, that's fine. Of course. That's what I'm here for, right? If you guys don't know, I'll show you. Okay. Open image. Oh, don't save it. Fuck. Wait, hold on. There we go. So these are what the excoriations will look like. You see, it's like these types of pulled things, these sores here. And then this is what meth mouth looks like. So you have like these black teeth that can fall out. And these broken char teeth. So if you use meth for longer periods of time, you'll notice this. Yeah, it's bad. It's really bad. That's why I said discretion is advised here. But yeah, this is what you'll have. Those are the two unique symptoms. I know this, I passed tear. Oh man. But yeah, let me hide that from you guys. So you guys, A, Twitch doesn't TOS me, and B, you guys can, you know, see this stuff proper. Yeah, at least you guys know what it looks like now, right? So that's what those are the two big boy symptoms of meth. Yeah, oh my god. Well, yeah, you can't really make a British joke. They teach this to students in regular public school? Depends on the school, right? Will they teach it to you? I have no idea. I mean, my school taught it to me. Not specifically meth mouth and those things. But they did teach me about these types of drugs. And I mean, you also learn sex ed depending on where you're located, so yeah. It all depends on where you are, I'd say. Okay, next drug. There's another stimulant that we can talk about. And this one is the one that used to be a big concern, but now is kind of faded into the background compared to other things. Nicotine. You guys remember nicotine back in the day? I assume all of you guys are 18 plus for sure. So nicotine is a drug that is in cigarettes. It's the main thing in there. In addition to all the tar and bullshit in there, it's also in vapes, right? So if you're vaping nicotine. I think there's like more weed vapes now. We're not going to cover those. Those are a completely different thing. But we're going to focus on like the conventional vaping, which is nicotine. Okay, so how does it work? So we have, again, our presynaptic and our postsynaptic, right? We're going to be using this for the entire explanation of each drug. All right. So let's say we have our nicotine, right? Now this activates, the reason why it's called nicotine is because it activates a receptor called the nicotinic acetylcholine receptor. Acetylcholine is a neurotransmitter usually used in like muscles, but in the case of this, it's used for activating the reward pathway. So nicotine acts on this nicotinic receptor, which then activates release of dopamine. Yes, I'll spell it out for you, Moshi. Acetylcholine. It's usually used for muscles and like autonomic nervous system effects. For example, like heartbeat or tears or sweating, things like regulation of sweating, things like that. But yeah, and that's not the nicotinic receptor, by the way. It's a different receptor. But yeah, let's focus on the nicotinic one for now. So this is the one that works. So the chemical nicotine will go to the brain and it'll activate the nicotinic receptor, increasing dopamine release, which causes your reward and which yields your high, right? Nicotine replaces it. Nicotine doesn't exactly replace it. It's just like a chemical yeah, exactly. It's like a chemical version, right? So it'll act on it. Again, all of these things are naturally found. These chemicals hijack that natural thing and allow it to propagate, is what I'm trying to say. So hopefully that makes sense. Okay. Now, the main symptoms of nicotine intoxication, they're less than a stimulant, right? It's more so just being more addicted rather than anything else. So just give me 1 second. Sorry. But yeah, so the main thing about nicotine intoxication is like general stimulant intoxication. Like you're just gonna have restlessness. right? So yeah. But those are like the 3 stimulants I want to cover. Hopefully they make sense. They just basically make you more aggravated, essentially. And they'll give you the nasal septum perforation and Crocade's piece, the bugs crawling on the skin. They'll also give you like the the skin excoriations, meth mouth, and you can also get the restlessness associated with nicotine. But there's also one other thing that I want to talk about. We've been talking about intoxication this entire time. What do you think is the opposite of intoxication? And what do you think will happen in the case when you take the stimulant away? Like when someone's addicted and you take it away just randomly. Let me get a drink. You're gonna have a little something called withdrawal. Right? So withdrawal, it's not like you're taking money out of the bank. It's that you're taking the drug away. So now you have a small problem. So let's say you hypersensitize. Actually, no, before we talk about withdrawal, let's talk about a concept called tolerance. Because that's probably more important. So let's write the presynaptic and the postsynaptic again. And this time I'm just going to put a few receptors on here for illustrative purposes. So normally, if we have the normal release of dopamine, we're going to have like the dopamine bind to one receptor, right? That's going to float around the synapse. But let's say you increase the amount of dopamine. So let's just say you use something like methamphetamine. You have more dopamine in the synapse. The body is going to adapt, by adding more receptors. But next thing you know, you get rid of that meth. So the extra dopamine is now gone, but the receptors are still there. See what I mean? So if you get rid of the meth, your body's not going to be getting the same signal and the same activation, which causes you to want it more and more and more until this goes down. And if you don't have that for as long as possible, you're going to get withdrawal. It can go down. Yeah, it can go down. It can go back down to baseline. Dopamine also gets reuptake. And I'm going to talk about something later, which is, another principle. But you're going to get withdrawal. And these symptoms are not good. So let's talk about stimulant withdrawal instead. And these are differing based on the drugs that we've previously talked about. But I'll just give a simple overview. So if stimulant intoxication causes, you being hyper, very agitated, very talkative, the withdrawal is going to be the opposite. You're going to have depression. It could be both physically or mentally. Right? So you could have slowed speech, right? For example, let me just find the stimulants page I made here. You can also have decreased blood pressure, right? Decreased sympathetic activity, slowed speech. Basically, you want to flip all the intoxication symptoms around on its head. And there's obviously like different withdrawal symptoms depending on the drugs themselves. But yeah, it's going to, flip everything around. And these are not fun to have, by the way. They are terrible to have because you're getting off of that thing. Your brain wants it, but you don't want it because you don't want to be addicted to it. And it can be painful. It can be bad. It can suck. But I don't believe these withdrawals will kill you, which is the good thing. Unfortunately, some of them can kill you, and that's the problem. That's the big problem here. Okay, so it can go? Yes. Okay, so now, let's talk about the second class of drugs. And are you guys all good on the stimulants? You guys all good on that? I got any questions, anything of the sort? That's like the easiest class of drugs. Yeah, you're good? Okay. So let's talk about the depressants. So depressants, kind of obvious what they are now, but I'm just going to copy this. But basically, depressants will cause depression, usually physical, sometimes mental, right? Not as much as, withdrawal from stimulants. Can those fake dopamine chemicals be reuptaked? That's a good question. I don't believe they can because they're different things. Because the main thing of these chemicals is to act on the presynaptic neuron somehow to release more dopamine. So it's not them being reuptaked, it's them modulating the uptake of the it's them modulating the release and reuptake of dopamine. That's what it is. Hopefully that makes sense. All right, so depressants can cause depression. So you'll see like respiratory depression. You can also see a decreased heart rate. Decreased mood, right? Sleepiness, sedation can be another effect. Right, so that's another one. What else? What else? And it also can disinhibit a lot of behaviors. So like being drunk. Disinhibition of a lot of behaviors. And yeah, that's pretty much it. So it's like, for example, let's just say you have a girl that you have a crush on and you're too scared to talk to her. So you take a shot of vodka and then talk to her because you're disinhibited then. Wait, there's depressive drugs? No. It doesn't induce depression. It might like induce symptoms of depression, but it's more so just like the physical signs. So like decreased muscle tone, decreased heart rate, decreased breathing, those types of things. And also disinhibition of behaviors. Relaxation, sedation, yeah, like Maddie's saying. That's what it is. So that's what it means. Yeah. There's different types of depression. There's mental and there's physical. The mental one's not really what we're going to be talking about today. That's a whole different story. But yeah. So let's talk about what if I mix stimmies and depressants? Well, then, my friend, you're going to be in for a whole lot of hell because it's not like if you mix a stimulant and a depressant together, you're going back to normal. That's not how it works. You're going to also have a shitload of side effects. The way to go back to normal is to, not do the fucking drug in the first place. Okay. So, we've specifically, gone over how depressants work. Now, let's talk about the one that's in the news all the time. And you probably know what I'm going to talk about. Opioids. I have friends who mix that stuff intentionally. Jeez. Oh, man. This is why education is helpful in this type of stuff. Alright. Opioids. You guys know what opioids are? You do? Hopefully you guys do. You know the big daddy, right? Fentanyl. Morphine. That's another one. Opium. That's a good one. Ew, Fent. Damn, you don't like Fent? That's crazy, bro. I'm kidding. Don't do Fent. But yeah. Nowadays in like emergency departments, I think fentanyl is used. Fentanyl and morphine are both used for pain. I think more so fentanyl now, depending on the ED, from what I've heard. But yeah, I'm not sure. Maybe Mr. ED doc, random person can come in. I like my opioids straight from the poppy plant. Swear to God, you guys are going a little too deep here. But let's talk about opioids. And before we talk about opioids, we gotta talk about an important concept in the nervous system that is very important with depressant drugs. Oxy, yeah, that's another one. Oxy's not as popular anymore for abuse, I think. I'm not sure. I think it's mainly Fent nowadays, but yeah, Oxy's another one. This is a fun time. So, let's first go over something called inhibition. Codeine, yeah. Another one, yep. All right, so inhibition is the simple principle, right? Let's just say you have a cell that gets excited and it spits out a bunch of neurotransmitters, right? Let's just say that. This is completely fake, by the way. And then let's just say we have a receptor here that's like an off switch. So a substance binds to that receptor and it disables the release of the neurotransmitter. This is inhibition. The basic principle of it is basically telling the excitatory cell to shut up. And the brain does this a lot where it has pathways specifically inhibited because it doesn't want to be activated unless necessary. So, for example, we could have a pathway that's supposed to release a neurotransmitter, but it's always inhibited. Right? So it's not going to release anything. But let's say we get rid of that inhibitor, or we just get rid of the receptor entirely somehow. Now the neurotransmitter will be released. So it's basically like putting a switch. When you click the switch, it'll release the stuff. If you release the switch, it'll stop releasing. Okay, so that's the principle of inhibition. Now let's go over the principle of inhibition in regards to the VTA. Brain actually releases natural painkillers or something. Mostly I'll talk about that. That is a specific, that's actually tied in with a specific drug that I'll talk about soon. But yes, we do release natural painkillers. That's correct. Okay, so the main neurotransmitter that's used for inhibition is called GABA. Gamma-aminobutyric acid. Don't even know the full name, just call it GABA. Everybody does, because it's kind of stupid to call it the full name, except unless you're like some like crazy neuroscientist or something. I'm not. So yeah, GABA. It's very inhibitory. It does all the stuff to calm things down. Now, GABA acts on the VTA system. So let's put the DOPA, presynapse. So this is the dopamine neuron, and this is the postsynaptic neuron. So the VTA actually has regulation by GABA. By releasing GABA, this line usually means inhibition, by the way. It'll inhibit the release of dopamine. So all of that dopamine that was previously there, no longer there. If GABA is acting on it, dopamine really won't be released, or it might not be released that much. Okay? So depressive drugs tend to circumvent this and get rid of this inhibition. So let's go over how opioids do that. All right? Hopefully you're with me so far. Opioids act on a receptor called the mu opioid receptor. Right? This is a specific type of opioid receptor. It's the only one that's important, really, if you're ever listening to anything scientific. You're going to hear opioid receptor. This is what it's talking about. Just keep that in mind. So let's say the opioid binds to this receptor, right? I'm just going to actually make it in black here. So the opioid binds to the GABA. GABA can lower down dopamine levels? Yeah. It can inhibit that dopamine neuron in the brain to prevent it from releasing dopa. That's correct. It helps with regulation of the reward pathway. But if we inhibit the GABA release, so this is gone, we're going to have the dopamine build up again. And after a lot of inhibition, you're going to have a lot of receptor buildup. And the next thing you know, you're going to have the reward and you're going to have the high. Right? So that's the main tolerance. Jesus Christ, who's revving their car outside my house? All right. Anyways, so you have the high, right? So that's basically what happens there. I'll start revving. That's crazy, bro. Why are you revving your car outside? That's crazy. I love you guys. All right. So, in addition to acting on the reward pathway like this to make you more addicted to the opioid itself, there's also other functions that opioids have. For example, respiratory depression. Respiratory depression, decreased heart rate, which is called bradycardia. You'll also have pinpoint pupils. You could also have, I think it would be, actually no, I'm not gonna say it. You could also have vasodilation. I'm not 100% sure on that one. Don't call me on that. Actually, maybe, sorry, vasoconstriction. Vasodilation sympathetic. Oops. That doesn't really matter. We're not gonna talk about that. No, sorry. No, I'm wrong. I'm right. Sorry. Dilation. But anyways, these three are the ones you really need to focus on for extra symptoms of opioid intoxication. Let's just say you have a patient that comes in with pinpoint pupils, barely or not breathing, and has like really low heart rate. Like the respiratory rate is super low. That's opioid intoxication right there. That's like a free question answer, but it's also very, very terrible to see in the ED because it's very sad. So let's go over another concept, because I would cover, you know, opioids and depressant withdrawal, but opioid withdrawal is a very, very, very important topic, especially in medicine, because it's the one withdrawal, it's one of the few withdrawals that we can medicinally treat. And let me explain. Opioid withdrawal. Okay, so let's say you're acutely intoxicated. Can GABA levels be chronically high? Sure, yeah. Your brain is your brain, right? Depending on what you do. Oh, we got an ad coming up, so we'll save the intoxication for a bit. But yeah, your brain is your brain. You can have chronically high or chronically low levels. That's like the main theory behind a lot of psychiatric illnesses, like depression. You have too low serotonin, so that's why SSRIs exist. They allow for you to, you know, have serotonin reuptake. That's an example. Yeah. Your brain, it's not like a static thing, your brain, right? It's a completely dynamic thing. Everybody is unique, is the thing I always like to say to you guys. Because since everybody is unique, you can have different levels of neurotransmitters in your body, which can cause different things to happen. Hopefully that makes a lot of sense. Alright, so we got an ad soon. There we go. I'm gonna take a little BRB, but feel free to ask questions. I'm just gonna take a quick cough drop. Okay, I'm back. Let me lower volume. Sorry, guys. Gotta fight through this stupid ass cough that I got here. Alright. I want to learn more about the Narcan. Well, we'll wait for the ad break to finish and then we can learn more about the Narcan. Okay, ad's done. Thank you so much, Twitch, for being such a pain in the ass. Okay, so we're talking about opioid withdrawal here. And the first thing, let's just say we have an acute intoxication of opioids. All right, so this means that you're having these symptoms here. Okay, so acute intoxication is usually treated via naloxone / Narcan. That's the brand name, and this is the drug name. This is the brand name, right? So Narcan is an inhibitor of the mu opioid receptor. So let's just go up to, actually, let's go here. So let's say, again, we have the GABA, we have the pre, and we have the post, right? So we have the opioid receptor, it blocks everything. Now let's say we give Narcan. Right, so the opioids can bind here, but instead, Narcan is gonna bind here. Or it can bind somewhere else on the receptor. And it's gonna completely cut this receptor from doing anything. Which means that which means that if you have an opioid circulating in your system, it can't bind because Narcan is already there and it's super strong. It's not gonna let go easily. So you're gonna feel like shit. Basically. And once you block those receptors, your body will start to return back to baseline. And that's when, you know, that's how Narcan works so quickly, is because it's very, very strong in binding that opioid receptor. And it saves lives, like, instantly. Like, you see somebody in an opioid position on the street, then you give them Narcan, and they feel much better in a few minutes because it basically just undid those effects. Like, you could look up YouTube videos about Narcan reviving someone. You'll see it in real life. It's crazy. But yeah, so that's how Narcan works. So that's what you'll do with an acute intoxication. And sometimes people might accidentally give Narcan based on what intoxication is there. Unfortunately, you know, if they're not really having an acute intoxication, they're gonna have those opioid effects, and it's not gonna be good for the patient. I mean, it's not gonna be life-threatening, but they're still gonna feel like shit. And that is your fault for taking opioids, so yeah, that's your own problem. It's funny, but yeah. Okay, but let's talk about the chronic withdrawal. So let's say you're addicted to opioids, right? The first thing we need to understand is that opioid withdrawal is non-life-threatening. So it's not a threat to you, your life, whatever. Not at all. Even if you feel like crap, even if it feels terrible, vomiting all the time, yeah, you're not gonna have those issues. Okay, so non-life-threatening, but let's just say you go through the withdrawal symptom. So there are actually medications to help with that. The first one, the best one to use, is called methadone. It is also an opioid antagonist. Or sorry, it's a opioid which will act on the receptor, but not as much as other opioids, right? So basically methadone will replace the opioid, but at a lesser potency. So it'll do the same job, and it'll help decrease the symptoms of withdrawal. And once you find like a dose that's good for you, then you stay on that methadone, basically. And I'll talk about like the dosing for withdrawal, because you might be thinking, oh, can't you just taper it off? Well, there's a bit of a small story with that. The second one is buprenorphine, which is a partial opioid agonist. So partial basically means it doesn't bind as well to the opioid receptor. It also decreases symptoms, right? And that's pretty much it, right? Those are the two medications that are used. I'll talk about another one in a second, but those are the two, okay? But the main thing with withdrawal in any patient is that you need to help yourself. Because if you're not, you know, helping yourself through the withdrawal, then what the fuck are you doing? You know? So yeah, you gotta help yourself through it. So when you're able to regulate yourself and make it so you won't be addicted to opioids and you won't relapse, only then can you take off the buprenorphine or the methadone. Because otherwise, these two drugs will have to be on for life. Because they allow you to not have those symptoms at such a terrible time. And the way that this is reinforced is basically like it's controlled. So it's given like at one time, X, Y, Z, you can start to space it apart and things like that as the receptors go down, but you're still gonna have to be on like a basal level until you can completely wean off through your own rehabilitation process. That's why rehab involves the patient's thing. It's not like you can just give medicines and it'll fix itself. It's not possible. That's the unfortunate reality of addiction. So yeah. I mean, you could also just go through the withdrawal by yourself. It's gonna be painful. You're gonna have a lot of symptoms like vomiting, constipation, sweating. You're also gonna feel agitated. But you're gonna be okay, right? You'll be alive. It's just gonna feel fucking terrible. That's the problem. Okay, now let's talk about if you have cravings again, right? So cravings. So let's say you withdrew from opioids and now you're starting to have cravings for them again because, you know, you still have that feeling in you. This is where a drug called naltrexone comes in. Naltrexone acts on the receptor as a partial antagonist, partial inhibitor, and it basically shuts things up before it can even start. So let's say you end up trying to take, it basically down-regulates those receptors so that, you know, you won't have to worry about having a craving. Just a small aside. Does that make sense? Like, this is the most important part of drugs nowadays because opioids are so prevalent in our society. It's crazy. Like the fentanyl epidemic, things being laced with fentanyl too. Like, it's such a small dose will kill you. And this is like the painful path through getting off of it. It's terrible. It's actually terrible. So hopefully you guys understand, that makes sense to you. Like the entire inhibition pathway, it's very simple, right? Like all it does, you just inhibit the inhibitor and then you get the dopamine release again. Very straightforward. All right, so back to what Moshi previously said about the brain's natural painkillers. And this is prevalent in alcohol, right? The world's most socially consumed drug apart from caffeine. I believe that's the case. Because I know some of you guys here have drank alcohol in the past, or maybe now, you know, just recreationally, right? I hate street fence so much. I think everyone does, right? All right, but yeah, let's just say everyone drinks alcohol. Fucking hell, like I just had like a party the last night that I couldn't go to, unfortunately, because of my shift, that everybody was drinking. Like there was a bar, right? People will do it, but nevertheless. So how does alcohol work? It's your favorite drink. So we have the same pathway, right? We have GABA, we have the presynaptic, and the postsynaptic, right? And then we have our dopamine. Okay, so what alcohol does in terms of the dopamine system, it releases a substance called the beta endorphin. It triggers that release. And this is the natural painkiller that Moshi was previously talking about. Endorphins are released as like a feel-good transmitter. It's used like in the gym, for example, you'll feel endorphins rushing through you as you finish a set because it feels good, right? So that's an example. But beta endorphins will act to inhibit the GABA again and then cause a dopamine release, making you addicted. But alcohol is very special. It acts directly on GABA receptors as well to cause depression, like respiratory depression. It causes the drunkenness, slurred speech. You guys have probably seen someone wasted before. That's exactly what you see with alcohol. With alcohol intoxication. Like, it is not fun. You need a DD, all that stuff. I don't know why people do it. I personally don't drink. I'm not a drinker. I don't like it. It's not fun for me. The only time I actually drank is on my 21st birthday. I drank wine. Tasted like shit. I felt a bit buzzed. Went to bed. Got sick the next day. I'm good, bro. I'm not interested. But if you like drinking, power to you. Just do it in moderation. All right? Because people can become alcoholics if they are not careful. Okay. So let's talk about So I talked about the intoxication. Yes, I did go to undergrad. I have seen drunk people. Exactly, right? Okay. So we talked about the intoxication, but another thing we need to understand is the withdrawal. And I have actually seen this with my own two eyes, especially in the ED. Okay, so it is totally there and is as severe as I'm going to tell you about it, okay? So the first thing you're going to see is autonomic instability. Right? This is basically, you know, you're going to start having a fast heart rate. You're going to start sweating. Everything is just going to be all over the place. Your stomach will start having issues. But everything's going to be all over the place, right? That's autonomic instability. It happens over time. But then you get into the hallucinations. Right? So this is hallucinosis. And this is when you start to see hallucinations. This is like about 6 to 24 hours. Yeah, Zatar, you'll start seeing hallucinations with alcohol withdrawal. So it's like 6 to 24 hours, you know, give or take. And then the worst part happens. Delirium tremens. This with alcohol withdrawal. Exactly. Yes. 48 plus. 48 plus hours after alcohol withdrawal without any medical support, you're going to start having delirium tremens. And you know, with opioid withdrawal, I said it's non-life-threatening. Alcohol withdrawal is life-threatening. It can kill you. It's very possible to do so. Delirium tremens is basically, if you know what delirium is, it's like you're actively forgetting everything. You start to lose consciousness, start to lose your sense of self. It just starts happening all of a sudden. The tremens part is exactly what you think it is. Seizures. You start to shake. You start to have tremors. Then that jumps into a full seizure. And I actually saw this in person in the emergency room, and it is very, very sad. Not fun at all. Do not recommend. But the way to, you know, dampen the effect of alcohol is using a benzo, right? Benzodiazepine, which is a sedative, right? It's a depressor, right? So as the alcohol is going away, contrary to popular belief, you can give benzodiazepines to help reduce these symptoms of withdrawal and to make sure that this doesn't happen. So hopefully that makes sense. And again, alcohol withdrawal usually involves like going to Alcoholics Anonymous, right? It's not Klonopin, not really Klonopin. In like an acute setting, you give like lorazepam, Ativan, right? For like, after a period of time, you can give Klonopin, yes, of course, long-acting benzo, but usually in the acute setting, you have a short-acting, from what I remember. But yes, so that's what you do there. Okay, and let's just do a short aside to benzos, because we just talked about it. Benzos are a lot like alcohol. They're also depressors. Benzos are also legal drugs, right? So they are prescribed drugs. They're usually given for sedation. They're called sedative hypnotics, and they will put you to sleep. And they're used for like, you know, conscious sedation. So let's say you're getting like an endoscopy or colonoscopy. You won't remember anything that happens during like the procedure when you're under the benzos, but you'll be able to follow commands and stuff like that. So that's how it works. So benzos, let's write the GABA system again. So GABA, the presynapse, the postsynapse, right? So there are different ions that are involved in the nerve conduction pathway. It involves sodium, potassium, and it can also involve chlorine and calcium, but we're not going to talk about that. The important one we need to cover here is chlorine. So usually when your nerve gets excited, the sodium goes up, potassium and chlorine, potassium goes down, inside the cell, obviously. Hey, Lev, what's up? Hey, GABA lover. And the chlorine stays like relatively the same, you know, it's the usual. Okay? So we have our sodium goes up, potassium goes down, yada, yada, yada. So let's just say we want to make the nerve less active. We want to make it so it's much harder to activate. When you increase an ion that is inhibitory, like chlorine, that's when we start to have the effects of essentially inhibiting GABA. Hopefully that makes sense. It's a little bit complicated, but feel free to ask questions if you're stuck. So what benzos do is they increase the frequency of opening of chloride channels, so chlorine. So it just increases the amount of chlorine inside the nerve, basically. That's what I'm trying to say. And by increasing the amount of chlorine, it's going to decrease the release of GABA, which will decrease the inhibition, which will have just a teeny bit of dopamine in there for mini reward. Oh, sorry. Yeah, no, sorry. It'll increase the dopamine because the inhibition is lowered, which will cause the reward and then the high. So yeah, that's benzos in a nutshell. Not as complicated as alcohol, but yeah, it's a prescription drug. Okay. And intoxication is that's the best part about benzodiazepines. The intoxication is literally the same shit. Oh wait, sorry. Intoxication is quite literally the same shit. You have like, it's just like less intense. That's basically what I'm trying to say. Okay. And the funny part is if you're trying to withdraw from benzos, you just give more benzos and you start to taper them off. I found that kind of amusing when I was learning it, because like that's one of the only drugs you give the same drug for and you start tapering it off over time. I don't know, it seems very counterintuitive. That's just me though. Oh my gosh. But yeah, hopefully that makes sense. All right, so those are the depressants. You guys understand what these are? You know, you guys understand what they do? All of the opioid withdrawal and stuff like that. I find that opioid and alcohol withdrawal are the two most important withdrawal symptoms because because they mainly regulate the two things that they are mainly either very life-threatening or they're, non-life-threatening, but really good to handle with medicines. One important thing to talk about is I say this all the time in my streams. It's the depressor plus the depressor effect. One app. Why are you guys harassing Lev? I'm the only one allowed to do that. Actually, never mind. We all did on Wednesday. I'll show you guys a doc later just to harass her more. But yes, let's say we combine a depressor and a depressor. Okay, so let's just say we combine alcohol or we combine benzos. So let's just say someone pops a few of their sleeping pills and they take a drink of vodka. It's going to cause them to go to the hospital. The question is why? Well, we know that alcohol does severe depression. So with breathing, heart rate, etc. Benzodiazepines also do the same thing, just at a lesser stage. But they build on each other. So you're gonna have, oh shit, a massive depression of everything. And this is gonna cause you to go straight to the hospital because of that massive depression. Alcohol and benzos will build up and shut your systems down. It's that bad. Like, seriously, if you see anyone try and do alcohol and benzos, keep them away from it. It is not a good idea. It'll make you feel like shit and you'll go to the hospital. Don't do it. Okay. But those are mainly like the main stimulants and depressor drugs. Now we can talk about the other drugs that you guys, want to talk about. For example, weed, CBD, Zero X suggested kava, and Maddie and Zero X suggested kratom. I researched those two. Don't worry, I have notes. But yeah, which one? We could talk about all of these. Also, we could talk about PCP, phencyclidine, because that one's really interesting. Okay, so I want to talk about PCP first because it's funny. Let's talk about PCP. Okay, this is called angel dust. I didn't even know this drug existed, and what Zataris was actually asking about public schools, I didn't even know this drug existed until med school. Maybe some of you guys did before, or maybe some of you guys just do now, but PCP or angel dust is a very, very interesting drug because it's the one drug where you have superhuman strength. You get really agitated and you start to fucking lift everything, throw everything. You're super aggressive. Like, it's to the point where you might need physical restraints. It's very interesting. It is super interesting. So, oh man, we're gonna add another neurotransmitter to it's worse than Roid Rage. It's much. Lev could probably tell you more, but it's worse than Roid Rage. Much worse. It is terrible. But yeah, so let's add another neurotransmitter to the mix. So we have GABA, right? We have the presynaptic, and we have the postsynaptic. Right, so now let's add another neurotransmitter called glutamate. I apologize, but glutamate is a stimulatory neurotransmitter, so it'll basically activate things. Right? So activating glutamate will stimulate release of GABA, which will decrease dopamine. That's basically it. Okay? But what happens... So this is like a glutamate receptor for GABA. But what happens if you block that glutamate receptor? This is what PCP does. So again, you block PCP, you block the continuous stimulation of GABA, which means GABA's gone. Now that GABA is gone, dopamine is freely able to be released, and you get the high. Very big high in this case. But yeah, that's PCP intoxication. And withdrawal is kind of weird. We don't really know how it works, what symptoms are there. Just go off of it and it'll go down. That's literally it for withdrawal of PCP. It's one of those weird drugs. But yeah, the most important part is like the superhuman strength. And also you have like nystagmus. That's one they really love to test on boards. Like, oh, the patient is on a drug withdrawal, having nystagmus. What drug is it? PCP. Go fuck yourself. I don't think that's a clinical thing that anyone will ever see, but fuck you. Anyways, yeah, I think the superhuman strength gives it away more. I think it might be a matter of the times. When I had Dare, PCP was there, but not Meth. Okay, yeah. Because when I had health class, I never really learned about PCP. So yeah, it's interesting. Okay. Now, we covered PCP because that's just one I want to cover about. Let's talk about these two. Let's talk about, actually, before we talk about those two, let's talk about something I like to deem the new age drugs. And this is just my own wording. It's not like a medical term. The reason why I think they're new age drugs is because they're drugs that are mainly sold as like boutique. Right? You can get them from like special stores and things like that without any problems. That's what I mean. So usually, you know, the stereotypes for drugs, I'm going to snooze the ad, are, you know, low socioeconomic status, poor neighborhoods, gangs, right? Or maybe it could just be suburban kids. Just like middle, lower class of the society area, right? So, these new age drugs are the complete opposite. These are more so the boutique drugs, right? So you'll see more of the high social economic status have them. Or you can see people that are, you know, hooked on weed, for example. Stuff like that. They're bougie drugs. Yeah, bougie drugs. Exactly. Right? So you're going to see more of that population by the types of drugs I'm about to show you. Because they're more so, you know, culturally accepted. And they're more of like experimental type of things, technically. Because I haven't heard about kratom and kava until you guys actually told me about it. I'm not going to lie. That's the craziest part. That's actually the craziest part here. So yeah. Oh my gosh. Not regulate. Yeah, not regulate yet too. Exactly. So let's first talk about the drug that is regulated in some places. THC. Also known as weed. And we can also put CBD here. THC and CBD are not the same thing. Right? They're completely different things. But they are from the same plant. The hemp plant. THC is harvested from a different part of the plant compared to CBD. I'm not going to say how or where because that's something you shouldn't really be talking about, but yeah. So as you guys know, marijuana is medicinal, right? There is medical marijuana and it's legal in some states, illegal in others. So it's really a statewide thing. But the thing I want to talk about the most is the mechanism because it actually uncovered a brand new receptor. So let's write the GABA thing again because it's important here. Synapse and the postsynapse. Okay? So, we're gonna write our THC, and it's gonna act on something called the cannabinoid receptor. So we're gonna call that CB1. THC acts on CB1, which inhibits GABA. GABA, again, since it's inhibited, it's gonna cause an increased release of dopamine, causing the high. So for all you stoners who are out there, your ass is getting high from weed, and it is, I believe it would be possible to be addicted, but I'm not 100% sure. Like people can get off it, get on it, etc. So again, this is like unfamiliar territory for me, and for a lot of the medical community as well. Okay, so that's THC, right? And it acts on the CB1 and also mainly the CB1, but it can also act on the CB2 receptor. And why do I talk about specifically CB1 and CB2, right? Let's write them both out. Okay? So, the cannabinoid receptors. CB1 will cause increased euphoria, appetite, mood changes, and it can decrease anxiety and stress. While the CB2 will decrease, like, inflammation and pain. So medical marijuana usually aims to do this, right? This is like a side effect of recreational marijuana usage. Medical will also do this, but it mainly aims to make this happen. So that's why when you're stoned, you have like the munchies, right? Because you have an increased appetite from stimulating those receptors. That's basically how THC works. But CBD is very interesting because if you guys in the know, then CBD doesn't have the same, high as THC. It actually doesn't really give you a high, to be honest with you. It's more of like the safer version. So, and safer in quotes, obviously. So rather than acting on the CB1 and CB2 receptors, CBD just simply acts on a separate area and modulates them. So it tells them to shut up, essentially. And also, it can decrease anxiety and stuff like that, but through a different mechanism. From what I've learned, which is interesting, right? This is a very interesting thing. It inhibits a neurotransmitter it inhibits an enzyme called FAAH, which inhibits a transmitter called anandamide. Like, yeah, this is a lot of in-depth stuff, but this is really interesting. So apparently there's this chemical in your brain called anandamide, and what it does is it produces bliss, like the blissful feelings. So by increasing this chemical through CBD, it essentially will help decrease the anxiety. Which is so fucking bizarre to me. Like, we go from simple neurotransmitters, like glutamate, GABA, dopamine, and the next thing you know, we're in fucking cannabinoid receptors, and we're in fucking anandamide for some reason, and that's where we start to get all these problems. What the fuck? So yeah, that's THC versus CBD. So, to put it simply, THC is gonna give you that high. CBD, no high. Just bliss. Right? You're just gonna feel more calmer. And in terms of like regulations, everything is like statewide in the US. I don't know what it is like in Europe and other places. If you guys are from there, let me know like what you guys think. But what the regulations are there for weed and stuff like that. But yeah, I am very interested to hear about it. Okay. I think we're gonna take a quick ad break, and then I'm gonna talk about kratom and kava as the last two drugs. All right, probably countrywide there. Fair enough. Yeah. All right, let's take a quick break for the ads. Okay. Yeah, I'm super into this. This is cool. I know the Netherlands has it legalized. Okay, that's interesting. Yeah, okay, so the country itself does it. I'd wondered if it would be like the town, is it legal or not? But yeah, it makes sense. Like the country does it because in the US, like states are technically like their own country in terms of like how we're governed. So it's like some states allow it, some states don't. It's its own thing. Like I know where I know like some places, they have CBD stores and things like that. Because recreational is legal. And in some other states, medical is the only thing that's legal. So yeah, we have those here. Yeah, you live in a state that's like that. Flying like marijuana is technically illegal because flying is governed by federal law. I believe, yeah, I believe that's the case. Right by the Costco? Yeah, me too. I have one right by my Costco too. I feel like they're trying to target that population. Uh-oh. Oh man. You guys right. Yeah. I believe that's the case. That makes sense. Yeah, federal regulation. Yeah, we're gonna have to see what happens in the future with weed. I mean, when I talk to some O'Hara's weed amnesty boxes, interesting. I know in like some physicians, they say like weed really shouldn't be recreationally legal because of like the symptoms. It can cause very bad symptoms if you don't use it in moderation. And there's like fair arguments for both sides. Like, should it be legal? Should it not be legal? Right? So can booze. Yeah, exactly. Like, there's a lot of things. I mean, I personally don't give a fuck. You do whatever you want with your body. It's up to you how you want to damage it or hurt it or, do whatever you want. But like, I don't really care. That's just make sure you don't fucking hurt yourselves in the process. That's all I care about. Okay. So let's talk about the two fun drugs, the two unregulated drugs. Start kratom. If you guys don't know about kratom, Let's actually look it up here. Because I actually didn't know about Kratom until you guys told me. It was in the thumbnail. But let me just show you. Here we go. Kratom is a herbal supplement that's apparently sold in gas stations. I did not know this. And it's used for a lot of effects, which I'll list here. Let's just see. I'm just gonna open this link. Okay, picture this. A completely unmodified plant that can increase energy and improve focusing while reducing pain, anxiety, and overeating. Kratom products have become more and more popular. Uppy and Downy. Why is that auto-modded? Oh, is it because Downy is a slur? Bro, what the fuck? Is that like a slur for someone with Down syndrome or something? Why the fuck is it auto-modded? I get... Wait. Is Downy a slur? It is! No! No, what the fuck, man? No way, dude. That's crazy. Nah. No. Oh my god. I was just trying to add the cute IE. No, now you're insulting Down syndrome people. I'm sorry, Maddie. You're canceled. I'm gonna cancel you on Twitter right now. I'm gonna say at Maddie. Oh shit. Maddie Latte said Downy and hates Down syndrome people. I'm not gonna say that. I'm not an asshole. Oh shit, it's a bad mouth. Oops, my bad. Oh, where's the page? Okay. Save draft for later. Oh, it did save the draft. Oh man. Energy. One of the best benefits of Kratom is that the extra energy you're sure to get. It's a stimulant, yada yada yada. Alright, unlike other stimulants, you shouldn't feel jittery or anxious. It has known alkaloids that can repress pain signals. It helps reduce anxiety, which is interesting. It helps improve focus, better sleep, stress reduction, weight loss. Is it just like a fucking miracle drug? What the fuck is this? What? Like, bro, it's like, oh yeah, it can do everything and it won't hurt you. No, everything can fucking hurt you, man. Like, sorry, what? Oh my fucking god, these drugs are gonna be the end of me, man. Ay. Anyways, so I have a few notes here about Kratom. Pretty straightforward. So, Kratom does quite a few things, like we just looked at. First, it partially activates the mu opioid receptor. So it adds like all of those opioid things, just this not like, you know, decreased heart rate, respiratory depression, but just not in like the same way as normal opioids, apparently. It also stimulates pain relief. So that acts on dopamine and serotonin, both of which are used to help reduce pain. Okay. Then we also have alpha-2 receptors, sympathetic receptors. And you know how, like I previously said, activating the sympathetic nervous system will cause like jitteriness, vasoconstriction, you know, fast heart rate, dilated pupils. Well, alpha-2 receptors are special in the fact that they're inhibitory. So they basically inhibit any of those sympathetic changes, which is weird. It's one of those really weird receptors. Basically, it helps decrease stress. So that's Kratom in a nutshell, right? Using all of the mechanisms that we previously discussed, you could probably link the dots, and it allows for all of these to occur via activation of these receptors. And again, too much of it will probably cause intoxication, but there's not enough research or data to show like what is gonna actually happen with this stuff. We're just gonna start seeing people coming in. Who knows? Rich people are gonna come in to the ED with like, oh my god, I took a shitload of Kratom, and next thing you know, I feel like terrible. People are having to go to rehab. Well, yeah, because you took a shitload because you think it's perfectly fine on a high dose. Makes no sense. Because when you're trying to wean off of these things, you're activating all these receptors here, which is just gonna, you know, not be nice for you in the future. So yeah. Again, the best stimulant is sleep. Sleep. Get proper fucking sleep, man. and make sure you're up in the day. I told like people in my ED that I don't drink caffeine. They're like, "Are you fucking crazy?" I'm like, "No, I just don't drink it. I don't like it." We have no research, just anecdotes, because the main seller of it markets it as a replacement for booze. Interesting, because that makes sense, right? Because you have the pain relief, you have the anxiety, stress decrease without like the symptoms of feeling drunk. So that makes a lot of sense. Okay. Now let's go over another new class drug. Kava. Not the fast food chain, the drug. If you guys don't know what kava is, it's pretty good. I'd recommend. Okay. Let's just look it up. Because I have my notes on here, but I'm just gonna look it up for you guys. Here we go. So this one was suggested by 0x. And kava is good. Kava is good. I recommend. Kava, the restaurant, is good. Okay, so what is kava with a K? Kava is a depressant drug. It slows down messaging between the brain and the body. It's made from the root or stump of the kava shrub. It comes in many different ways. Okay. So how is it used? It was traditionally used in the Pacific Islands. Crushed, chewed, ground the root, yada, yada, yada. Many Pacific Islanders continue drinking it, and there are rituals. Interesting. Okay, herbal preparations. Kava extract is used in some herbal preparations and used in the treatment of insomnia, stress, and anxiety. I mean, makes sense because it is a depressor, right? There's no safe level of drug use because it's not regulated. Use of any drug carries some risk. Yep. And that's pretty much it. So let's just scroll down here. So the impact of mood and environment. Drugs that alter a person's mental state can have varied effects. There's also long-term effects like mood swings, apathy, dry skin, malnutrition. Okay. Lots of things that are present in most depressors that we've covered. And it is unlikely that a person will become dependent on kava. Ongoing and frequent use of kava known to harm. Okay, so according to the Alcohol Drug Foundation in Australia, not really crazy addictive from the looks of it, but again, take that with a grain of salt because, you know, with moderation. So yeah, and you don't want to be mixing this shit with anything else either. So let's talk about the receptors, okay? So kava, first thing we need to know is it increases the GABA receptor, specifically GABA A. There's two GABAs for some reason. So by enhancing the GABA A receptor, it's not like a benzo, right? Because again, depressants are very similar in how they work, but in this case, it's just activating a different receptor to give you that decreased stress level. In addition, there's the increased dopamine, and there's the increased norepinephrine, which will all help decrease that, you know, agitation that you're feeling. And it'll allow you to, oh, sorry, increase here. So it'll decrease agitation, and it'll allow you to, you know, just relax, even out, mellow out. But that's what kava is. I feel like kratom is the one that's way more scary in terms of the new age drug because we don't really know too much about it, and it activates so many receptors that are just like, you know, not really, I don't know. It's one of the, like what Maddie said, if people have to go to rehab for it, that's kind of fucking insane. Let me look it up, actually. It's marketed. It's too good to be true, in my opinion. Kratom rehab. Let's see. Yeah, kratom addiction treatment. Oh, sweet. American Addiction Center. Perfect. Let's see. Zoom in. Oops. Okay. So kratom, yada, yada, yada. Stimulant effects. We talked about that already. Opioid use disorder. Yep. Using kratom to manage opioid symptoms and to reduce their opioids. Yeah, because it's a partial agonist, right? So it might help. Okay. Kratom use, effects of kratom. Okay, so you already talked about all this stuff. Is it safe? There's an increased concern for the serious health effects that may result. Additional research is required to address some of the following safety concerns: contaminants, safety issues, interaction with other drugs, long-term effects, overdoses, seizures, apparently. Jesus Christ. What the fuck? Seizures, dude. That's crazy. But yeah, apparently there's rehab. Is kratom addictive? Here we go. So, there's no specific criteria. It may have addictive potential. Makes a lot of sense. Psychoactive chemicals activate some of the brain receptors. Yada, yada, yada. Okay. Yeah. and it's obviously gonna have depressant withdrawal, right? Because it is trying to even you out, and then when you withdraw from it, after take it for a long time, you're gonna have that depressant withdrawal. So yeah, that's basically how it works there. But yeah, that's pretty much all of the drugs that I want to talk about today. I feel like the last thing we should probably close off on today is how do you obtain, like, what's the gateway? Not how do you obtain it, but what's usually like the gateway for getting drugs? And then the second thing is how do you get help? Right? Because we talked about the mechanisms of all the drugs. And I really hope the stream and all the things I just talked about really help you guys understand how each of these drugs work. But I feel like the important thing to talk about is how do people even get into it in the first place? And if you're into it and you're in that contemplation stage, where do you get help? Right? So first, talk about the gateway and what you shouldn't do. This is all stuff that you shouldn't be doing. So usually teens are very, very susceptible to getting drugs, either through like upperclassmen, or they can get it from bad role models, or they can get it from friends. They can basically get it from anyone, right? Illicitly. Because if you're young, you obviously can't get these drugs, especially alcohol, right? Younger, I know a lot of people consume alcohol when they're younger. Nowadays it's weed, right? That 0x is right here. Nowadays it's weed, right? People start smoking weed like crazy. And I have had some people come into like the pediatric ER and they've eaten like THC gummies. And they quote unquote thought they were candy, likely story, buddy. But yeah, sure. They thought they were candy, of course. Yeah, my thought they were candy my ass, bro. All right. But yes, so there's a lot of things that can happen. Friends, well, SES, gangs, also high SES, parents maybe. Who knows, right? There's a lot of things that can happen that can cause drug addiction. But the number one thing that this all has in common is peer pressure. Everyone else is doing it, so why shouldn't I? This is what stupid teenagers think when they start doing drugs. I know I was a very stupid teenager. If you guys know me from my old days, you probably know I was a fucking stupid teenager. But yeah, peer pressure is real. Again, bride drug arc. I didn't do drugs. No, I was mainly just on the computer a lot. But and I don't know if that's like a fucking bad thing or something. I mean, now I'm a fucking VTuber, so you know, everything happens here. But it's basically like everyone else is doing it. Why shouldn't I? There's a lot of epidemics of teen vaping, teen weed use, there's also teen alcoholism, right? Teens can drink alcohol. And of course, since the liver is developing, not a good idea to drink alcohol until you're older, right? Not a good idea because you're still developing your liver, your brain, everything. So taking drugs can hurt the developmental growth of those areas. Some countries, it's 18 years old or 16 years old for alcohol. And don't clip it. And for other countries, it's like the US, it's 21 for alcohol. So it really depends on your country, right? I personally think 21's a good age. Some people disagree with that. That's fine. I mean, there's other people I know that have drank earlier than 21. People do it all the time. But especially when it comes to stuff like cigarettes, just, yeah, be careful. That's the number one thing. So peer pressure, right? So be very careful. Just know that if you ever, if anyone, ever thinks about doing drugs or something like that, just show them the stream, show them this VOD if you want, showing them like how each of these drugs work, what they'll feel when they'll go to the hospital and things like that. Because yeah, it can happen. But then how do you get help? Let's just say you are addicted. You need help. You need the ability to get rid of these things. Well, first of all, you can talk to your PCP, right? They'll forward you to rehab. For sure. Because PCPs will always ask, like, drugs, alcohol, tobacco. And if you tell them, like, hey, I'm feeling like quitting, let's do it, PCP will give you rehab. and they'll also prescribe meds to help reduce, you know, the symptoms. I mean, in rehab specifically, there's methadone, but let's say I mixed up PCP with the angel dust. Yeah, no, primary care provider, sorry. Let's just say like there's different meds. Like for alcohol, you could take like naltrexone, right? To reduce the cravings. But with alcohol withdrawal, you go to like AA, and that'll help reduce it. So it's really important to reach out. There's also like support groups. Alcoholics Anonymous. There's also hospital for psych. So there's like a lot of avenues that you can take. And I believe there's also hotlines. Not 100% sure. But you can always look up and see like, how do I get off this thing? And obviously the best way is to get away from the stimulus. Whether that be a friend, the role model, the gang, the parents, whatever. Anybody that made you do this type of stuff, get away from them because they're going to do nothing but harm your health. From what I can see. Right? Depending on the country you're in too. Some will help out with a safe place if you're taking drugs. Yes, of course. That's usually like a rehabilitation facility over here, right? But some of them will help you out. Portugal example. Interesting. I didn't know about that. Yeah, so it does depend on the country. But yes, I wholeheartedly believe that a lot of developed countries are more than willing to help get people not addicted to drugs because, you know, that's just an overall negative for society. It really sucks that we have drugs flowing in everywhere and being obtained illicitly or abused legally. Like one thing with opioids, right? Especially like the prescriptions. You guys already know that we track everything, right? Like medical, if it's a controlled substance, the pharmacy is tracking your prescription and how much you get and if you're getting too much. They are tracking that. And also in the case of opioids and other drugs, well, let's talk about opioids. I saw a kid today, you know, opioids can cross the bloodstream and go into the baby. So the baby can have opioid withdrawal symptoms on birth. Because the opioids from the mother can go into baby. And it's not good. Yeah. Unless your house. Oh my god. I mean, if your baby does have opioid symptoms, you just give him fucking naloxone. Like, why do you want to give a baby naloxone, man? But yeah, that's what I'm trying to say. Nevertheless, you can see like all of the negatives of this type of stuff, right? Hopefully you guys can understand that as to how bad these drugs can be. And hopefully you guys also understand that shouldn't be peer pressured. No matter what, like, in my case, I'm an adult. I've never touched a single drug in my life, right? I'm very clean. I'm very happy about them. But the main thing I want to, but it's a really good life without them. Alcohol here and there in moderation socially, that's fine, right? Like, no one's gonna penalize you on that. I say caffeine is a drug because I personally dislike caffeine. It's a stimulant. Everybody's addicted to it. But people drink it. It's up to you whether you want to use it or not. It's not going to kill you unless you use a lot of it and you get caffeine intoxication. But I personally still don't like it. And a lot of medical students and people in the healthcare field do. You know what I'm saying? Also weed, right? Panera. Maddie, I remember you did tell us about the Panera thing before. I remember the charged drinks. And then there was the weed, right? That's another drug that's like 50-50, right? So it's up to you what you want to do with your body, with your life. But I really hope this, you know, big segment medical presentation type of thing really educated you on what drugs are and how all of these drugs work. Again, this is going to be on YouTube. So if you guys do want to watch the VOD, I'm also going to make shorts on this. I wonder if I should try and cut like a long form video as well of just like each drug and how it works. But that's probably going to be way too long. But I'm not ending the stream just yet. I'm just ending the segment here. But yeah, that's it about drugs. If you guys have any questions, comments, concerns, anything you guys want to talk about, you know, let me know. I'd be down to chat about it. It's definitely definitely a very interesting topic because everybody loves illegal drugs. Tea greater than coffee, don't at me. Yeah. I mean, I remember you said this before. I agree. I actually no. You said this before in Discord. I made tea for myself right then and there because I was craving tea for some reason. Oh my fucking god, dude. Oh man. Oh, I love drugs. Alright. I love teaching drugs. I don't love drugs specifically. Why do people shove bags of drugs up their various holes? Maddie, you should be able to know that. It's because they can smuggle them. You know? Next thing you know, they'll have a fucking bag full of drugs up their ass and they'll be like, oh yeah, I fell on it, by the way. I talked to like people in the ED. The legend of things being up people's asses is not true, unfortunately. My friend has not seen a single thing up a single person's ass, and I'm very sad. Man, I'm very sad. I want to see at least one case where there's something up some people's ass. They're saving it for their last year. Oh my fucking god, dude. Oh man, that's awesome. Okay. I did another thing I want to cover, tech related. You guys want to talk about that for a sec? Hold on, before I end stream. Oh, give me K2 release. No, I mean we could talk about that a different day. I'd be down for that. I don't think I can talk about tomorrow because I'm busy. But yeah, there was this. You guys want to see this? Oh my god, you guys are gonna love this. Fuck, wait. Let's see it. Okay, hold on. Where the fuck is my? Oh yeah, I have to go to working. That's why. Apple. It's been leaked. That Apple will use Google Gemini in their next version of Siri. No fucking way Apple decided to fucking cave on their Apple intelligence and just be like, okay, we're gonna start using Google Gemini now. Oh my fucking god. Apple's AI ML was Apple work again. The first comment is what happened to Apple AI. Incorrect. Okay. Google. Let's read Gurman's article again. I think you overcorrected. This is a leak, so it's obviously not 100% true. Maybe it's not even 100% true from this fucking stupid ass Dixerto. But, dude, if this is true, it's gonna be so funny. I already know Apple like tries to outsource to ChatGPT, or at least is will in the future. But yeah. Also, oh, this is Azure. Also, I have something I did want to talk about. Like, if you guys remember, I talked about DHH's Omerkey. Unfortunately, it caused a lot of schism in the Linux community, where the interesting part about Omerkey... Actually, let me switch to... Hold on. Before I talk about this, let's just switch the categories to software. And let's also change this to tech chats and chill. Okay, my bad, guys. But yeah, let's talk about like the Linux bullshit. Yeah, like that's the thing. Like, if you guys don't know, a distro in Linux is basically just the Linux kernel with some extra shit on it, packaged as an ISO. That's literally all it is, right? Linux kernel, core utils, and then like desktop environment. Basically the ability to load a quote-unquote OS onto your computer. That's what a distro is, in my opinion, right? That's the thing I said in Discord today, right? There's like a lot of Linux quote-unquote chads out there who act like they're the fucking arbiter of truth for Linux. I'm just out here like, why? Right? That's an absolute who cares if it's a distro. Right? I agree. Like, so what if Omerkey is just a bunch of bash scripts? It's being used by a bunch of people who want to convert to Linux because it's so simple to get started with. What's the problem? Like, don't you want more people to use Linux and go away from Windows? I don't know. It's like, oh, you're using Linux, but not my preferred Linux. Like, who gives a fuck, man? They're using Linux. Like, let's just read this DHH tweet. I love DHH tweets. They're fun to read. You can spot an aggrieved Linux loser by the attempt to gatekeep the term distribution like it's a royal distinction of honor. I don't give a fuck what you call a compilation configs, tools, and programs with a custom installer that ships off an ISO. The level of petty nerdery relies on the misconception that your precious terminology has any meaning to outsiders. As it's obvious that they don't have any interest in climbing your little status hierarchy by playing your silly games, I don't. You can call Omarchy a distro, a remix, or dot files dump for all I care. Whatever your fragile nerd ego needs. If you must demean newcomers who didn't honor your silly rights and rituals, I'm just gonna keep pushing Linux to a new audience by shipping the racism. And that's the thing, right? I feel like the majority, and call me like me being a hot take for this, I feel like the majority of people don't switch to Linux because of the community surrounding it. Like, of course, every community has good and bad eggs. I'm very lucky to be surrounded by a lot of good eggs in the Linux Windows AI world, right? Love all you guys. You guys are great. You guys help me out with a lot of things. I already talked about why I'm on Linux. I'm still on Windows, etc. But it's like some people are just way too arrogant and pompous to the point where it's just like, why the fuck should I even bother switching to your nerd ass thing when I have Windows or Mac and it works properly? You need to convince absolute normies to switch over to Linux. And it's not like by replicating Windows or Mac. You can do that with Zorin OS, right? But it's like you want to push something that somebody really likes to use. And unfortunately, a lot of people end up distro hopping, including me, in terms of, you know, finding things to use on Linux. But this tweet really resonated because it's what makes me, you know, very upset about people not switching to Linux. I mean, I agree that people should switch to Linux. I agree that more games should run on Linux because it's a good idea. It makes a lot of sense. It's the OS that doesn't fucking spy on you, right? But it's just like people are so out there, like some people, that just makes it very unpleasant to newcomers. Like, let's say you install a program for the first time and you just get shamed out of existence if you say something wrong. Who the fuck is gonna want to use your program? Right? Who's gonna care? I don't know. Like, that's just something I really want to cover because, you know, people are people. They'll do their own thing. Or someone just tells you to RTFM. Yeah, like, read the fucking manual. This is like, for example, so if you guys know the Discord, so you guys know that I've always learned programming by asking questions. Asking questions to people, looking at examples, because if people know something better than I do, I'm gonna get their knowledge. That's basically it. I'll be annoying, sure. I might seem annoying at first, but the more I get to understand something, the more I'll be able to make better software. And by asking questions and making friends and networking in the community, it really helps. And for example, with Rust, it's well known that the Rust community can be a bit of a pain in the ass at times, but the Serenity Discord server, the Discord bot library, these guys were like the nicest people ever. They helped with everything in making my bots, and they were so nice. I know a lot of them to this day. They're great. And that's the type of community you want to have for people who want to use your software. The Serenity does it. They're so chill. I'm a mod there now for some reason. I used to be a mod. There's like 2021. I haven't really used Serenity in a while. I just use it for my bots. But yeah, I know a lot of the people there. They're great people, and I love talking to them occasionally. So yeah, it's great. It's great. They're awesome. And there's a lot of communities out there that I like that. And I feel like the developer, especially with like the rise in AI and GPT, I feel like the developer landscape has turned into a place where it's way more chill compared to what it used to be, you know? Like, you guys remember Stack Overflow back in the day? And everybody would like shame you if you ask a stupid question. But with LLMs, there's no stupid questions anymore. Like, you just ask the LLM and it'll tell you everything you need to know. So it's very nice in that regard. Back in the day, it's gone. Stack Overflow is still there, right? You could still use it, but I feel like people just use LLMs a lot more nowadays, including me, right? I've used LLMs to ask questions while coding all the time. I still check it. Sometimes I check it on occasion, but yeah. LLMs do pull from Stack Overflow. So that's the fun part. But yeah. So it's like a huge paradigm shift in tech where you have the pompous assholes, they're getting shunned out of existence and put in like their own echo chambers of sorts. And then like normal people are able to get into programming at a much more accelerated rate compared to before because people are just nicer. I don't know, maybe that's just my experience being in here for in the hobbyist space for a long time and knowing a lot of people in multiple spaces, but that's what I personally found. You know, I don't know. It's like I learned everything by talking to people. And I'll probably do a stream at some point talking about how to learn programming, what to do, what to get started with. But I don't know, like this tweet from DHH really, really, really resonates with me. Like, get rid of the fucking morons that try and shun you for things that you did, or like RTFM comments. Like, if you don't read the documentation, then sure. Like, if you don't read like obvious documentation, then sure. Like some people, like in Tabby support, for example, sometimes I'm just way too tired to answer questions. I just don't say anything at all, or I'm too busy. Like, that's just me, right? I'm working fucking a medical school job, so obviously I'm busy. But yeah, I own an Arch Maintainer a few seconds of my life. Yeah, right? I mean, I guess the Arch Maintainer helped you out. I know. Like, I find that, you know, and if you don't know what Omarchy is, we can find it here. What the fuck? Why the fuck they use this picture for DHH, bro? The fucking F1 racer arc. That's crazy. Okay, but yeah, here's Omarchy. I showed this before on a different stream, but basically it's like the quote-unquote Mac OS of Linux, where everything is just there for you. It's all configured, it's all installed and everything. So yeah, that's what Omarchy is. So it's like Arch Linux with it's just a bunch of extra auto-config things, so that you have like the benefits of Arch Linux with a bunch of extra stuff on top. And obviously every distro, every setup has its caveats, including Omarchy, but it depends on like what caveats you want to grab. You know what I'm saying? So yeah. First advent of code, they helped me optimize. Using the first advent of code? Wow. Damn, I don't even remember when that happened. They helped me optimize something. That's cool. It kind of sucks how advent of code is changing though. I'm not going to do it this year because I'll be busy. Oh, my first. Okay. Fair enough. I remember, yeah, they're changing the format now, and it's like, I don't know. I don't know, man. It seems like something that I personally don't like, and I'm probably not gonna do it this year because, like, I'm gonna be busy with rotation, but also I'm just not really interested. If there's not like the, you know, melding and doing the leaderboard shit, that was always fun. Maybe there still are leaderboards. I have no idea, but yeah. Oh man. Also, for you guys, what do you guys think? Because there's private leaderboards. Okay, good. So, what do you guys think of? So my friends online wanted to play a co-op game together. What do you guys think about that for a stream? You guys want to, you know, see that? Maybe just like a Gorilla stream midweek. I don't know. I'd be down to stream it with my friend. It's like a little collab. I also got some collabs coming up that are kind of secret right now. Could be fun. All right, I'll do it. I'll do random streams during the week with that friend. What game? I'll show you guys the game when we get to it. So long as not Valor. Yeah, no, we're not playing Val. Don't worry. My normal friends play Val though. I mean, if they're ever down to, you know, join an Overwatch stream, that's fine. But like, I don't know if it's a good idea, to be honest with you, knowing like the boys group chat and everything. That's always a fun time. And yeah. Anyways, I think it is getting a bit late. Yeah, you know what I'm talking about. You guys know what I'm talking about. Yeah, you guys know. Oh man. Anyways, I think I'm getting a bit tired now. I'm also starting to run out of a bit of steam, so I'm gonna probably end the stream here. You guys are awesome. Thank you guys so much for joining. I always appreciate every single one of you. Posture check. Well, thank you. I appreciate every single one of you, both old and new. Oh, wait. I'm this is in Discord, but for channel points, do you guys want me to add like outfit toggles? I'd be down. Like if you want to redeem like the angel outfit or something. Anyways, shit, I forgot to put the doctor outfit for this stream. Whatever. But yeah. I'm gonna find someone to raid. More use for these points. Yeah. If you guys want to suggest like channel point redeems and stuff like that, I'd be happy to toss them. Or like a chat. I could also ask if you guys have a channel point icon idea. I could ask Vix for it too, so we can make something there. She probably wants the money too, so I'd be happy to pay her for small commission for like a channel point icon and stuff like that. But yeah, I'm going to raid someone. This is fine room for 40k. Let's raid Stux. All right, perfect. All right, guys, it was nice talking to y'all. I really appreciate all you guys for pulling up, chilling, vibing. If you guys want to join my Discord, feel free to do so on my website, kingbry.dev/monomy. You could join there. And otherwise, I'm going to see you in the next stream, which will probably be next week. We'll figure out something to do, suggest stuff in the Royal Lab. And that's pretty much it. See you guys next time. Bye-bye.